Welcome to Mastering and Guideline in Ultrasound and Echo. Hello everyone, here we have another multiple choice question. First one, a tech got this two view for wall motion abnormality view as apical 3. Is that correct or not? Is apical 3 or not? And based on this view, which walls you are seeing? Here on the apical window, we get this view. What is this view? And say each of those structure. What is here? What is this one? What is this? And what is this jet? And when we use this view. Next, on this apical 2 chamber view, what is the most important abnormal you can see? Except forget about the ejection fraction, all those stuff. The most important see that take your attention right away. What is that? What you called it? And do you think any coronary disease in this case present or not? If there is, which vessel? This view, as you can see, apical 3. What setup on this image, color, Doppler is wrong? And what is the result if you do this? What is the result of evaluation of the valve if our setup is wrong, like this one? Okay, we have pulmonary vein Doppler in apical 4 chamber view. We got the spectral like this. Which of them is SD and AR wave for measuring maximum each of them? Which spot you select? I hope you write your answer. Now let's go to the find out what is the answer for each of them. Here, as you can see, it's kind of the reverse. Here is mitral valve. It's kind of the reverse apical for off axis. What do you mean? It's mean here, if you look at here, tricuspid show up and almost LVOT open too. So this is completely wrong, and I notice many tech they get apical 3 like the reverse apical 4. What does mean reverse apical 4? Means twisting too much clockwise, is almost between 9 and 10 o'clock marker. In that case, it looks like you're reversing, getting apical 4 chamber view. So in this case, how you fix it? You have to twist a little clockwise in this case. So this is almost between 9 and 10 marker. You have to turn it more clockwise until this appear RV. Here is LV, mitral valve, and here is RV and RA. So twisting too much in apical 3 can give you this impression. So in that case, this is septum, not anteroseptal, is inferoseptal, and this one is not posterior. It will be kind of between lateral wall and posterior. So it's completely wrong. Try. Whenever you get apical 3, if you see tricuspid, even a little of the tricuspid, or you see large RVOT, you are off axis. You are wrong, and wall motion for representing that image completely will be wrong. Next one. Here is a classic view. Usually I haven't seen anybody use it, but practically I use this view a lot, especially on those patients that they don't have plaques and PSACs. it helped a lot. And this is apical view for pulmonary artery. How you do it in apical 5, if keep going angle up, suddenly you can see very clear pulmonary valve and pulmonary artery. Here is LV and RA. Okay, and here is PI. This view is help a lot in those patients that doesn't have plaques and PSACs for pulmonary, checking pulmonary. Even though most of those patients have good subcostal and we can get it. But give it a shot, try in your other patient, you will surprise how much clear you will have it. But just when you do that maneuver from apical 4, go 5 and continue angle up a little higher, sometimes you have to pull down or pull up, you get clear this view. Next one, here is apical 2. I am sure almost all of you answered correctly because I had a lot of case study and clips on these topics. Is wall motion abnormality. You can see inferior basal is aneurysmal, bulging, not moving during all those systolic and diastolic. So this is a classic, typical, very common heart attack in myocardial infarction on the RCA, basal inferior, supplied by RCA. Here, one of the common mistake, not the tech, but usually for some reason, other tech that use that machine play or for any reason, they play with the scales, especially. Always when you start doing echo, your first test, always look at your scale. Sometimes your hand hitting, touching, and it change. Here on the heart, scale should be around 55 to 60 for adult. Here you can see 19. In that case, first of all, it create aliasing, color changing. When you decrease scale in that area that has high velocity, when you decrease it, it create aliasing, and in that case, when you use this setup, you overestimating all color, like the here we have MR, you overestimating jet area. I saw some cases, not some, many cases, they didn't focus on the scale. Just be aware of that. Here, last one was pulmonary vein pulse Doppler. As I mentioned many times, never go by the shape of the Doppler for measuring or anything. Always correspond with the ECG. As you know, a normal person, S is taller than D. If you go by those assumption, okay, S is taller than D, you pick up this one as a S and this one as a D. That is wrong. Or here, some take, I notice, even they didn't look at all. So they take it as S and take it as D. Always look at the EKG. EKG after QRS is S, and after T is D, and after P is the reverse. Name is there, is negative. So it will be AR peak and duration this time. I hope you like it. Put on comment whatever you have in your mind if you have any more questions. Up to the next time, have a good time.